We have with us Dr. KEKUNNAYA, who's going to be talking on pediatric cataract step by step. On to you, doctor.
Once again, Dr. Chitra and ARC, thank you so much for having me today. I am talking about step-by-step pediatric cataract surgery today. That's not the end of everything, as Dr. Love said. It could be just a beginning, but there are much more important things than surgery. Having said that, one should not really neglect the cataract. When you look at already, we know that it's not that one type of cataract will be there. We have different morphology and we have different etiology. We have different systemic conditions when we deal with cataract surgery. Before we do this surgery, we need to take that adequate preoperative assessment. That's very important. That will help us to decide which way to go. Either a systemic condition or the status of the iris, dilatation status, the axial length, associated systemic condition, where we have to implant, where we can't implant. The preoperative checkup will tell most of this, but there is a huge variability. And even in terms of morphology, there are many types of cataract, starting from total cataract to near total to partial visual obscuring cataracts. These are the things. And to add to that, we already discussed the eyeball length or the diameter could be different, and they can have an anterior part of the cataract or posterior part or central, nuclear or total cataracts they can have. Ultimately, we would like to be here with the clear visual axis, lens in the back. Axis size is quite good. There is no donut or posterior capsular opacification or visual axis opacification. That's the goal of the surgery. But in the whole process, there are other things to take care. I will talk about some of the important steps. I will show just 3-4 videos to explain this. There are 5 important steps. As you all know, the first one is anterior, capsular axis, followed by lens aspiration, IOL implantation. Before that, we might do anterior vitrectomy, following primary posterior capsular axis. I put the word there, grip. That's very, very important. That's a important mnemonic, I would say, for capsular axis. If you ask 100 surgeons, they will say 90% of them will say anterior capsular axis is the most difficult in children, other than GA, other things. So the mnemonic for this, to have a good grip on anterior capsular axis, grasp, regrasp, and inward pull. These are the 4 things you need to remember when you do a capsular axis, that is grip. I just would like to show this video from start to end. This cataract, you can see, in the initial part of anybody's training, I think it's better to stain it. I don't usually stain. Stain has 2 advantages. One is the visibility. Second one, it makes the elasticity of the capsule to be different. Your capsular axis becomes easier when you stain that. So generally, lesser the incision is better. I would always prefer a foldable lens. I know socioeconomic status consideration has to be given, but as much as possible, use a very, very minimally invasive, as less as possible. Try not to open the scleral pocket or scleral incision. Try to do this 2 side port incision. Inject viscoelastic. Once you have done that, use this cystitome to make an initial nick. This may not be possible in every patient because it can vary from patient to patient. Sometimes when you are placing the nick there, you will have a thick plaque there. There, you have to use a scissor or any kind of other kind of forceps. So grasp, regrasp, always pull towards in, that is towards the center. Always be watchful of the edge where it is running. Always measure, if you want to measure what's the size of the capsular axis, you can keep this nucleus size as a kind of guide for your capsular axis. Grasp, re-grasp, inward pull. Keep on doing it. As you are at the initial stage, you might have to do it 10 times, but once you get experience, you will make it better and you will become a master of it. But this capsular axis is different in an infant, it's different in a toddler, it's different in a 5-year-old, and it's different in a 10-year-old, because the elasticity varies from age group to age group. The next step, whether you have to do a hydro dissection or delineation, generally it is not required, and in a total cataract, better to avoid, because in case if there is a dehiscence of the posterior capsule, your nucleus might go. In this case, you can see when I'm trying to do aspiration, this kind of pearl calcified material is there. So you need to be prepared anytime to change it to phaco aspiration in 10% of the children. The nucleus is so thick that they won't even come. So you can see that central part is very thick. I follow a pattern. I come from periphery to center. This way, I always have a scaffold at the center so that it will not hit the posterior capsule. Once I do that, anterior capsule is done. Take out all that is possible, and also try to do a lens epithelial cell, clearance. You can see that tag of capsular axis was remaining. You can complete that, and then you can start the posterior capsular axis. Again, very similar way. Make a nick. Don't make a big nick so that there will be some. Am I not audible?
No, in between it gets blank.
Video is switching on.
Switch off my video, is it?
No, your video is going off in between.
In between, it's there, it's seen. You carry on. It keeps coming on.
Okay. So the capsular axis, we need to continue. And then with that, you will have a complete capsular axis. Once that is done, you need to implant the lens. Now you can see the capsular axis is not the size what I intended to. We might have to increase it after aspirating all that. I am going behind the lens here because in this video, I just wanted to show both the techniques where after implantation and before implantation. So this way you can shave it off. Always keep a very, very high cut rate for the capsular axis. And then even for the vitrectomy, capsular axis, you can keep it at a little bit lower rate. And then you can complete the capsular axis and try to remove as much as lens epithelial cells as possible, because immediately after surgery, it might look good, but in the long run, it may not look so good because lens epithelial cell proliferation happens very rapidly in children. So always try to suture this wound and also give a intracameral as well as subconjunctival injection, so that at the end of the surgery, even if the child does not put the eye drops, you are safe in that way. So that's about a simple pediatric cataract surgery. As I said, the lens aspiration can be finished very quickly. The posterior capsular axis, this is a rexis which is being done. This is another video. I'm showing the similar thing, but you can see again, it has to be smaller than the anterior capsular axis. And once you have the posterior capsular axis there, implanting the IOL, you need to be careful. Always implant the leading haptic, and then you can nudge the trailing haptic. And then you can use, once at this stage, you can use sometimes the Simcoe also, you can use it. This is another video. I'm just quickly showing it. Again, the capsular axis here, completing it. You can see always you're seeing the edge here. Don't be in a hurry. One by one or segment by segment, you can complete. Once you have done that, okay. I thought it's a 15-minute talk. I'd put it for 15 minutes anyway.
Okay, carry on.
So this is the final video probably I'll show, and then I'll stop it. This is the patient with the, you can see posterior capsule is already open. I'm trying to do the Axis with the staining it. And then here I'm coming from periphery to center, but at some point of time, I could see the vitreous was coming. Stop there, complete the vitrectomy, and then do all the aspiration. Once you have done, you can see there is an elliptical shaped opening in the posterior capsule. Then assess again at this point of time, can I put a single piece lens or a 3-piece? Or with the 3-piece, should I want to capture it or not? Here we assessed, we thought that single piece can be implanted. Same principle, leading haptic goes inside first, and then the trailing haptic goes. And then whenever there is a posterior capsular rent because of the lenticonus in this case, don't nudge, just rotate the lens, just nudge it. That will take care of that. So this is the lens in place, and always I use a switcher in most of the kids, unless the child is really old, and then we close it by a switcher. And this is all that. It looks like a very dense cataract, but you can see with the capsular axis, you can also do a plaque axis. You just have to hold the plaque. You don't have to use a real vitrector there. With the plaque axis, you can remove the whole part in one go. Sometimes you might have to use a little bit of scissor there and then complete the surgery. Secondary, I will not show because of the want of the time. The last slide, I would say all of that is very nice, but always remember real follow-up. That's the mnemonic, I would say. Refraction, visual acuity at every visit, IOP check at every visit, check for alignment and rule out amblyopia at every visit. And also look at the IOL, look at if there is any tilt, look at there is any disturbance in the visual axis clarity. And the last thing, remember grip when you do a anterior capsular axis. Thank you so much for the attention.
I would just ask a couple of questions to you. When you're doing the PCC with just after puncture, do you believe in injecting viscoelastic to push the hyaloid face behind? Number one.
Yeah, I used to do that, but I don't do it anymore because unless when you make that initial puncture, there is a vitreous strand coming, I probably do it. Otherwise, that was a practice I used to do in the initial part. I don't do it anymore. But one should always make sure that when you are completing the axis, you should not have any kind of vitreous. It can happen in some of the unusual vitreous face cases like post-lenticonus or Stickler syndrome. Otherwise, generally that behind the lens capsule injecting, I don't do it personally anymore.
Urli, can you ask?
Yes, sir. Do you use triamcinolone for vitrectomy, anterior vitrectomy, or do you not?
Not really, Morlidhar. I don't use it, but there are many people use it. But I don't think so. There is a problem of using it. But I feel, sometimes the residue can go inside and then they can remain. It might cause a glaucoma. But unless I compare using it and not using it, I can't comment on that. Generally, I don't use it. I don't ever use it in any of the cases.
And what would you do if your anterior axis is compromised in any way? Let's say it's a traumatic or your anterior axis is extended. So question for all the panel. And what are your options? I mean, I know it should not happen, but sometimes.
It really happens. Whatever you do, in some of the cases, it is bound to happen in everyone's hand. One of the thing is, if you realize it early, I'll try to abandon and then try to do it from the other side. At least 270 degrees is covered. That's number one plan I have. But if it has gone beyond my control, I can't even get it back. It's already so big. that it's gone out of control, use a scissor and cut it. If still there is a support from the bag 270 degrees, I will implant in the bag. Otherwise, I will implant in the sulcus with the capture. That's a very good procedure in this type of cases. You asked about band, the traumatic cataract. If there is a band of capsule remaining, I'll keep that band as a support. If it is not, again, I'll use the above said two principles, even in traumatic cataract. That's my kind of protocol in short. There are variations, but these are in short.
Shall I add one thing to that?
Yes.
One thing what we can do is we can give, suppose rhexis is lost on one side, after implanting the IOL in the bag, we can give a relaxing cut diametrically opposite, so that when in future the capsule contracts, the lens doesn't decenter.
Posterior optic capture against PPC with anterior vitrectomy and IOL. Is there any recent difference of thought about interface opacification and all that?
I think the Dr. Jagatram's Institute paper has not found any great difference between the two. Only advantage of optic capture probably is that you don't need the vitrectomy, and oxidative damage which has been associated with vitrectomy you can avoid. And another advantage which Dr. Jaspreet's paper suggests is that you can use Berger space in very small children, because bag may be very small, and sometimes in very young children, if your optic is mostly behind the pussy capsule, you have a slightly larger space. Disadvantage, of course, it is technically a little bit more challenging than putting it in the bag. And you can use a certain type of lens. 3-piece lens IOLs have a learning curve. You have to remember that. And sometimes to put it in the bag and then capture the optic behind sometimes can be a little bit challenging for the beginners. In experienced hands, everything can be done. But sometimes
my first choice remains IOL implantation into capsular bag by and large single piece. 3-piece IOL we capture some time, and I think in the PCO rate and complication there is no significant difference whether you have posterior capture, which we are doing for the last few years, or whether you do in the bag implantation of IOL and posterior capsulotomy and anterior vitrectomy. There is no significant difference in that.
Thank you.
There's just one point. There's one bag in the lens, which is popularized by Mary Tressignan. That's a very special lens where she does this optic capture. She claims in Europe it's been showing good results, but we have no personal experience. So
I think those IOs are not available in our country, are they?
No, they're not available. I mean, you can source it if you want, but.
So I think we'll keep the discussions based on the